Now let's see neurology conditions. The first condition is increased ICP. The normal ICP intracranial pressure is 5 to 15 mm of Hg. Risk factors: cerebral edema, infection, craniotomy, hydrocephalus, meningitis, spina bifida, and tumors. Signs and symptoms like loss of consciousness, pupil changes, constriction always, less than 0.5 mm, headache, seizures, bleeding and vomiting, Cushing triad, that is hypertension, bradycardia, bradypnea, anticonvulsants, osmotic diuretics, and hyperventilation is a medication we will give to this patient. Management: if the patient is having long-term ICP increased and excess of CSF fluid secretions, we will go for VP shunt and craniotomy for the patient if required to decrease the cranial pressure. Nursing assessment, signs and symptoms, management, ICP management, and ABC monitoring. Alignment of the patient should be always semifowlers or like supine with head elevation of 30 to 45 degree, depends upon the EVD inserted situation. If no EVD, then we will make the patient supine with 30 to 45 degree elevation. Avoid neck movement, aseptic technique, calm and quiet environment. Meningitis, inflammation of meninges, increased ICP, mode of transmission droplet. We need to place the patient in droplet precautions. Signs and symptoms: we can see two signs, that is Kerning sign and Broding sign. Kerning sign, the patient can't able to lift the limb for a 90 degree elevation, and Broding sign, when you make the patient supine and flex the neck, the patient will have automatic hip reflection, the legs will get bent up. Diagnosis: we will do with lumbar punctures, CSF fluid will be checked with the glucose of decreased and protein will be increased content. Nursing actions: we need to monitor the droplet precautions, ICP monitoring, frequent positioning and range of motion exercise to the patient. Seizures: it is an abnormal activity in the patient brains. This condition we will be having multiple types, that is absent or petit-mal seizures. It is common in children, where the children will be getting blinking or staring of the same object for long times. Myoclonic seizures, involuntary jerky movements. GTCS, labored breathing, frothy secretions, tongue bite, incontinence of bowel and bladder will be common. GTCS is generalized tonic-clonic seizures. Management: safety, lateral position to the patient to prevent aspiration. ABC monitoring, suctioning out to avoid fracture. Tongue plate will be placed to prevent tongue bite. Airway management, safety management. Treatment: phenytoin we will give to the patient for anticonvulsants. Stroke: this is an disturbed cerebral circulation. There are two types of stroke. The first one is ischemic and the second one is hemorrhagic. Ischemic is caused by the any kind of blockage in the cerebral arteries, and hemorrhagic is a rupture of an cerebral arteries. In this, black plaque or atherosclerosis is a very common for the ischemic. Signs and symptoms: again loss of consciousness, aphasia, dysphagia, ataxia, sensory impairment, incontinence, contractions. When we go for a stroke, we can see the patient will have a slurred speech, facial drop, and the limb drop. It is a confirmation test for a stroke, and we will activate the stroke code for the patient. We will do the fast assessment and we will move the patient to the immediate treatment care. Paralysis: there will be quadriplegia, paraplegia, hemiplegia, and pentaplegia. Fast assessment: face weakness, arm weakness, speech slur, time for transport. Management: Alteplase we will start Alteplase we will start for ischemic stroke. Warfarin and heparin, aspirin will be given within the time limit for the patient. If it is hemorrhagic stroke, we will take the patient for craniotomy for the fixation of the arteries. Nursing management: neurological assessment, ABC monitoring. Increased ICP to be assessed, we will go for EVD insertion, and all the things will be maintained. Self-care deficit need to be met to the patient. Myasthenia gravis, voluntary muscle weakness. This one causes because of acetylcholine decreases. The patient will have swallowing difficulty, ptosis, dystonia, respiratory failure, and dyspnea. Tonsillons, neostigmine, pyrodystigmine will be present for the patient. Interventions assess the ability to swallow, suction, coughing, and breathing exercise, airway. Myasthenia crisis, then the patient is having hypertension, bradycardia, and respiratory distress. Increasing the dose is needed here of the medication. Cholinergic crisis, withhold the medicine and antidote to be given, that is an atropine sulfate. Parkinsonism, dopamine deficiency. Bradykinesia, the patient will have slow movements, rigidity, resting tremors, mask-like face, stupid position, shuffled steps, progressively small handwriting, rolling of saliva. In stupid posture, we can see even the patient is walking very slow with an involuntary movement. Levodopa, carbidopa, amantadine is an management for this. Nursing intervention, chewing and swallowing to be started. The patient will be referred to the swallowing therapist. High fiber diet, fluid to be administered 2 to 3 liters per day. Avoid pyridoxine, block the effect of medications. The next condition here is GBS, Guillain-Barré syndrome. It is an self-immune attack syndrome where the patient will have a melanin layer getting destroyed due to an untreated or improper treatment of streptococcal GI-RTI infection will be affecting this one. The patient will have hyporeflexia, they cannot able to grab the words, they can't able to do their activity because their nerve stimulator, the nerve transmitter is being affected in this part. Here we can see the CSF fluid, protein elevation. The difference here in the meningitis and here is like that the protein will decrease and glucose will be decreases. Here the protein will be elevated. Intervention, symptomatical management, assess the complication of immobility, respiratory complications, treatment, immunoglobulin, infusion to the patient. Spinal cord injuries, we have cervical, thoracic, lumbar. In the cervical, the patient will be affected with the facial and respiratory, thoracic, chest, trunk and bowel bladder, lumbar, bowel bladder and paraplegia. Management, IV methylene prednisolone, anticoagulant, antispasmodic, stool softness, laminectomy, spinal fusion, nursing interventions, airway pattern, safety, collarbone, log roll, spinal board, extended position, fluids, neurological status and physiotherapy to the patient. Here we can see autonomic dysreflexia, that is T6, injury, hypertension, sweating above level of injury, bradycardia, pounding headache and flushed face. Precipitating factors, bladder distension, UTI, catheter block, pressure, extreme temperature, restrictive clothing. Intervention, we need to give the patient high Fowler's position with avoiding stimulants. Avoiding stimulants like noisy, bright lights, all these things. GCS. When the patient has a GCS less than 8, the patient needs immediate respiratory management. The maximum score of GCS is 15, the minimum score of GCS is 3, where the eye response goes for a 4 and verbal response go for a 5 and muscle movements will go for a response of 6. So when it goes less than 8, we will go for the patient on airway management immediately, advanced support. Cranial nerves, we have 12 cranial nerves, olfactory, optic, oculomotor, trochlea, trigeminal abducens, facial, vestibulocochlear, glossopharyngeal, vagus, accessory and hypoglossal. We will add the image of this, all the nerves conditions with an actions. Raymond sedations, anxious, agitated, restless and or both. This is a good sign. When the patient will have 3 or less than 3 score, the patient is ready for extubation. This scale we will use for the patient extubating from the ventilator. If it is less than 3 or 4, 5 or 6, the patient is not fit for airway management on by himself. Thank you so much.